Greetings and welcome to CE Institute. My name is Selena Belisle. I'm the founder and one of the instructors here where we teach geriatric bodywork and massage. Now, in today's little lesson here, I'm going to share with you what's part of a larger training unit in our pre-recorded home study for bone and skeletal changes with geriatrics. I'll review joint replacements, arthritis, and more. Sometimes during the training, you might hear me reference other units of training or student handouts to download, and that's because this training is part of our pre-recorded home study. However, whenever I can share some training units publicly and for free on YouTube here, I do just that. So we hope you enjoy this training unit that's used in one of our CE classes. If you like it, please like us and follow us on YouTube and our other social media so that you can continually support our free training efforts by providing this material. The first thing that we'll review in our aging bone processes is osteoporosis, which comes from the Greek language. Osteos means bone, porous means porous in the Greek language, so osteoporosis means porous bone. Bones are naturally honeycombed or spongy in appearance. If you look at the picture on the right-hand side, you'll see spongy bone up there. That's bone tissue, and it's not solid. There's little tiny pockets between the bone tissue, and those pockets increase in size as we age, as we lose bone tissue. So osteoporosis is when there's larger holes in the appearance of our bones. When we have these larger holes, the bones can become weak and they can break. And fractures can occur in very serious advanced osteoporosis cases simply from a sneeze. You might see a little old lady sneeze. She could break a rib doing that. Seriously, it has happened. And in advanced osteoporosis cases, minor pressure on the bones could also fracture the bone. 54 million Americans today are estimated to either have low bone mass, osteopenia, or osteoporosis. According to the Cleveland Clinic, osteopenia is an early sign and risk factor for osteoporosis. Now, everybody who develops and diagnoses with osteopenia is not necessarily going to digress or transgress into osteoporosis. According to the National Council on Aging, as many as 18 million Americans currently have osteopenia, and everyone over the age of 50 is at risk for osteopenia and bone loss. Osteopenia is triggered by age-related bone density loss that happens with a sedentary lifestyle, lack of weight-bearing exercises. That's why sometimes people go get dogs and they're walking their dogs every day, right? Excessive alcohol and consumption, smoking, and more. Osteopenia used to be thought of as a women's disease. However, men develop osteopenia too. The Cleveland Clinic reports women are 4 times more likely to have osteopenia than men. And that's simply because women's bones are generally smaller than men. So when we start to lose bone tissue, that really puts the bones at risk. The Cleveland Clinic estimates that more than 40 million Americans have osteopenia. So their estimation of osteopenia amongst older adults is much higher. And about 1/3 of adults older than 50 have some degree of bone density loss. That means 1/3 of the clients who are 50 years or older on your massage table have some type of bone mass loss. The New England Journal reports those who are diagnosed with osteopenia, 10% of the women with moderate osteopenia will transition to osteoporosis within 5 years. And 10% of women who have advanced osteopenia will transgress to osteoporosis within 1 year of diagnosis. The prevalence rate of osteopenia increases rapidly with women at the age of 60, and the prevalence rate of osteopenia with men increases rapidly at the age of 80. And in addition to being gender prevalence, we also have a race prevalence with osteopenia and bone mass loss as well. The percentages for 1/3 of white and Asian men over age 50, about 1/3 of them are affected by osteopenia, so it's by race. And the percentage for Hispanics is 23% of Hispanic men over the age of 50 are at risk for osteopenia, and with blacks, 19% of men are at risk for osteopenia over the age of 50. However, that's still sizable populations that are at risk for low bone mass. On this slide here, you can see what more compact bone looks like on the left. The space between bone tissue is quite minimal and it's overlapping, so the bone itself is quite strong. But with the development of osteopenia and then osteoporosis, you can see the loss of bone tissue and how that creates larger spaces between the bones, which make them brittle and at risk for fracture. The National Osteoporosis Foundation reports that osteoporosis results in geriatrics because of a variety of factors, including a decreased dietary intake. Geriatrics tend to eat less. They have poor appetites and sometimes they're sick and their illness prevents them from eating. And also economic factors can play in the reason why somebody might more rapidly have bone mass loss or bone density deterioration. If they can only afford to eat boxed and processed food instead of get wholesome food with real vitamins in them, then that can also contribute to bone mass loss. We need to have our vitamins to maintain bone mass. The intestine does not absorb calcium well from the diet in people over 65 years old, okay? And the body responds by releasing calcium from our bones into the bloodstream. We need calcium for muscle firing and daily activities. And even if we do have a good diet and we are getting enough calcium in our diet, the body doesn't really absorb the calcium and other vitamins as well as we age. So it starts leaching from our bones to get the vitamins and minerals it needs for daily function. Also, as we age, we have less vitamin D as we're exposed less to sunlight. Many of us are afraid of getting skin cancer, so we stay indoors and we put sunscreen on and hats when we do go outdoors. Some geriatrics are in nursing homes, hospice facilities, they're institutionalized, or they might be housebound. It might be very difficult to get outside and get that daily dose of sunlight, which gives you some vitamin D. And as we age and as our skin deteriorates, the skin is also less capable of synthesizing vitamin D. So as we age, we're not getting the vitamins and minerals we need to maintain healthy bones. Bone loss can occur in our feet as well, and our arch can become less pronounced, which can make us shorter. And so there's a number of reasons how and why we become shorter in our senior years. The skeletal spine is also affected with bone mass loss as we age. The vertebrae, as they lose their mineral content, they can become thinner. And remember, the body leaches mineral from our bones to provide these minerals for the body, as we can no longer get these minerals from our diet, even if our diet is good. The spinal discs in between the vertebrae can also lose fluid, so they become thinner as well. So eventually, the spinal column becomes more compact and compressed with a thinner disc and the thinner vertebrae. and this can also contribute to a loss of height. In addition to the spinal vertebrae and the spinal column becoming more compressed and compact, losing your height as you age, we often have a curved spine. Hyperkyphosis might set in for those who don't work really hard at their posture. So there's a number of reasons why we're getting shorter as we age. So with our geriatric clients, we are going to adjust the amount of pressure that we're going to use in their massage or body work due to bone mass issues. So anybody with low bone mass, osteopenia, osteoporosis, depending on the severity of the disease, that will dictate how much pressure you can apply in your massage or bodywork service. If they simply have low bone mass without an osteopenia or osteoporosis diagnosis, then you can probably use a little bit more pressure than somebody who has advanced osteoporosis. That's the type of client, if it's a woman, if she sneezes, she could break a rib, literally. So we're going to use very light pressure with them. We might avoid something like the thoracic cavity or back massage and just do maybe hand or foot massage, or even one of those geriatric sessions, such as a sweet session. You also might want to reconsider the techniques you use with your geriatric massage and bodywork, such as I wouldn't provide tapotement to a moderate or advanced osteoporosis. Any type of striking of the body could cause fracture. And on the right-hand side of this screen, you can see a compression fracture in a vertebrae that's happened in the spine. And this can happen with geriatrics. Now, you might have somebody come to you that has a compression fracture and they're walking around. I'm not going to massage the client's back when they come to me with a compression fracture with a vertebrae. I don't want to apply any more pressure on a compressed fractured vertebrae, okay? Even techniques like cupping, where you have reverse suction, if you're pulling upwards, you're also pulling not just the skin and the underlying fascia and muscle, but you're also pulling on the bone. And sometimes we can really pull up 1 or 2 inches. But if you're pulling a very weak bone in 1 to 2 inches in an opposite direction than where it's fixed, you could fracture it. So be very careful with the amount of pressure you're using with geriatrics, whether it's with your hands. Hot stone massage would be ill-advised because sometimes the stones hit the bones. They're not supposed to, but in geriatrics, they have less subcutaneous fat. So they could also be subject to fractured bones if you're using stones. And things like cups as well could fracture bones too. The 3 most common medical issues in an aging geriatric vertebral spine is spinal stenosis, spondylolisthesis, and disc generation. We'll review all 3. About 1/4 or 1 in 4 of geriatric clients who get on your table would have a diagnosis of spinal stenosis. It's estimated about 27% of the elderly are diagnosed with this disease. Spinal stenosis is when the canal where nerve roots exit the vertebral spine narrows, and there can be pressure on those nerve roots, and that can cause pain and other undesirable side effects. It's usually the result of osteoarthritis, sometimes bone spurs develop on the spine and more, and anyone over the age of 50 is at risk of developing spinal stenosis. Lumbar spinal stenosis is the most common occurrence. Sometimes spinal stenosis can also occur in the cervical spine, and I've never seen a case of spinal stenosis in the thoracic spine, although I'm sure it can happen. It's much more rare. Now, sciatica can be a side effect of lumbar spinal stenosis, okay? That's when a channel where the sciatic nerve exiting the vertebral spine is compressed. Okay, that's a form of spinal stenosis. Spinal stenosis can also mimic vascular insufficiency, where there would be pain down the leg, especially while walking. Lumbar spinal stenosis is worse when you're leaning forward, okay? And cervical spinal stenosis in the cervical spine can lead to extreme weakness or paralysis. And I've even seen one client who had a atrophy in their hand from cervical spinal stenosis. Their cervical spine was so compacted, and I believe on one side, and I believe it was from holding the phone between his shoulder and his ear for decades when he was in charge of this very large company. He was always on the phone with conference calls before, and didn't like speakerphone before they were using speakerphones and so forth. And that actually caused a compression on the nerve root that caused muscle atrophy in his hand. And I was considered a fabulous therapist because I did a lot of traction, cervical traction for this stenosis. And I also did a lot of massage of the muscles that were shortened and tight. And we were able to regain some space in the cervical spine. And he got about 50% of his thenar eminence back returned. And he was able to brush his teeth and hold a fork again, which he could not do with that cervical spinal stenosis. So spinal stenosis can be quite debilitating in a number of ways, and people could seek out massage, especially when Western methods and Western medicine fails them. Now, how many of you have seen a little 1-inch scar above the vertebral spine? This is a fairly new laminectomy surgical scar. And the stitches or staples or whatever was used to close the surgical incision have recently been removed, and it's proliferating or scabbing right now. Laminectomies are one of the Western medical procedures that's used to treat spinal stenosis when it's severe or debilitating to the client. And a surgeon will go in and remove a piece of the vertebrae, part of the lamina, hence the word laminectomy, to relieve pressure from the nerve root exiting the spine where it's compressed, creating the spinal stenosis. So laminectomies are performed to treat various back conditions that result in pain from spinal cord compression or nerve damage. Here's a wonderful illustrated depiction of what a lumbar laminectomy would look like. And it's also showing the spinal nerve compression in the upper middle picture where it's red, and you can see the nerve root exiting and the irritation that might be caused by that compression. So what surgeons are doing is they're removing that small piece of lamina to allow a greater nerve root space to exit to relieve that compression. Now, there are all types of laminectomies being performed today. There's microlaminectomies, and I have one client that's had 4 of them over the past 10 years, which sounds kind of scary with the risk of infection and so forth. And I have another client who had what they call a window of their spine cut out, where multiple vertebrae in a row in succession have had part of the lamina removed on the same side, which to me is quite scary. I'd hate for that client to fall. They seem at larger risk to have a major spinal cord injury or vertebral fractures. Now, when somebody has a laminectomy, you're not going to press in the local area because you could be pressing directly on the spinal cord, which is not a great idea. I wouldn't use hot stones or cups or apply any other massage tool over the laminectomy surgical incision either. So, what does this mean for massage therapists who have a geriatric client with spinal stenosis? It means a number of things and adaptations that we can do. First of all, seeking physician approval and direction for your massage or body work would not be unheard of for a couple of reasons. First of all, the doctor might not want your client lying in a pronated or in another position for an excessive period of time, and they might put a time limit that they can be in certain positions. Second of all, they might limit the amount of pressure that can be used in back massage, especially with a limited time. And third of all, if your client is older and forgetful, or they might even have dementia or Alzheimer's, you wouldn't want them to think that the massage worsened their condition. And spinal stenosis can become quite severe for some people. They might be initially diagnosed and it's tolerable, but the disease can progress and become intolerable. And we wouldn't want them to think that it's the massage that made it worse. So if you do have a physician referral or direction and approval, that helps mitigate your geriatric client, hopefully, from thinking it was you that made their disease worse. Now, with lumbar spinal stenosis, I usually wouldn't use one of those body cushions that kind of brings the shoulders forward and elevates the lumbar area, because that could increase pain and also increase the pressure on those lumbar spinal roots. Sometimes it can improve it, but whenever a client with lumbar spinal stenosis is leaning slightly forward, such as opening the door, and we'd always want to open the door for our lumbar spinal stenosis clients, because when they're leaning forward, that can increase their pain in some, not all, but because it can increase pain in some, that's why I provide those advisements. Also, the nerve compression could become worse anytime that we're pressing in the area. So we want to know if they have cervical or lumbar spinal stenosis, or where the spinal stenosis is located, so we can limit the amount of pressure we apply in the area so we don't make the condition feel worse for the client. Spondylolisthesis is another commonly diagnosed spinal issue for geriatrics. It's common in people over 50. Almost 1/4 of the population has spondylolisthesis in their senior years. And it's caused when one vertebrae slips over another, like you can see in this picture here to the right. It's usually L3 slipping over L4, and that can cause nerve compression. It can also cause something called pars fractures, where the transverse processes literally break off the sides of the vertebrae because it slips so far forward, the ligaments are holding on to the bones and they fracture because it's very thin bone in those transverse processes. Spondylolisthesis can create pain and can also inhibit daily activities and exercise and more for geriatrics and anyone who suffers with this disease. Surgery is one of the few options that can be corrective or curative, although pharmaceuticals and massage may help. This is what a surgical procedure to provide curative or relief to spondylolisthesis would look like. They literally put screws into the vertebrae to hold them in place so that one disc does not further slip over another. And this is usually in the lumbar area of the vertebral spine. When spondylolisthesis occurs in the low back, it's referred to as lumbar spondylolisthesis. And while it's L3 that usually slips over L4 most commonly, it can be as low as L5 slipping over S1 as well. And it can occur anywhere in the spine, but again, it's most common in the lumbar area. When a vertebrae slips over another vertebrae, moving forward and compressing the sciatic nerve, you can create sciatic conditions where there might be pain in the low back and traveling down the leg, as well as weakness, burning sensations, itching, or even numbness and weakness, which could cause falling for your geriatric client. Now, we do have some massage and bodywork contraindications. Your client would know of their spondylolisthesis diagnosis because a physician would provide that after diagnostic imaging. It's not something, if somebody's self-diagnosing, then that's not good enough. They need to actually have imaging, whether it's X-ray or MRI or what have you, to diagnose this condition. Now, when they are diagnosed, when you're lying your client in a pronated position, you cannot press in the area of spondylolisthesis, because if you're pressing directly over the vertebrae or on the sides of the vertebrae, you could push that vertebrae that's already slipping forward even greater forward, which can create those pars fractures of the transverse processes breaking off the side of the vertebrae if they haven't already. Also, what will happen in lumbar spondylolisthesis is you want to not provide deep tissue or stripping or even stretching work in the hamstrings. And that's because as one lumbar disc, vertebrae slips further over another vertebrae, what's happening is the hamstrings will start contracting to prevent the vertebrae from slipping even further forward. If you release the tension in the hamstrings, and they might have pain in the hamstrings, most of the times they don't, but if the hamstrings are super tight and contracted and maybe even lost range of motion with that increased muscle tension and stiffness, if you release that, that might allow the vertebrae to slip even further forward and cause more pain. Now, spondylosis sounds like spondylolisthesis, but it's not the same thing. Spondylolisthesis is when one vertebrae is slipping forward over another vertebrae. Spondylosis is simply an umbrella term for degenerative changes within the spine. So things like arthritis of the spine, bone spurs of the spine, and you can see a wonderful depiction of a bone spur developing on the anterior vertebrae with the arrows right here on this spine on this slide. Wearing and tearing of the discs between the vertebrae as well would be considered a spondylosis diagnosis condition as well. Degenerative disc disease is one of the top 3 diagnosed conditions of the spines for geriatrics. It's also referred to as DDD. It's not really a disease. It's simply another umbrella term to explain degenerative conditions that can produce pain from a damaged or worn vertebral disc. Degenerative disc disease, also known as DDD, is most common in the cervical or lumbar spine, and it's categorized with 4 different stages. Degenerative disc disease is diagnosed by physicians when regular use of the spine causes pain or when there's disc degeneration that's found on diagnostic imaging. Now, the 4 stages, I'll read them to you right here. These are also in your student workbook. Stage 1 of DDD is dysfunction. The disc have begun to degenerate and you may develop mild to moderate pain. Stage 2 of DDD is the dehydration phase. Your spinal discs begin to dry out. This causes them to lose flexibility and some of your height. So another reason why geriatrics can become shorter with age. The pain can worsen at this stage and become an everyday experience. In stage 3, it's the stabilization phase. Your spine attempts to stabilize itself. It's almost like you're trying to create a homeostasis within your body. And that can lead to spinal stenosis, where you have a narrowing of the bone tissue where the nerve roots are exiting the spine, and then that can cause compression on the spine, which surgeons love to provide laminectomies for, right? When you have that stenosis with DDD, that can be significantly painful, which is why people are opting for surgery. And in stage 4, the final phase of degenerative disc disease, you have collapsing of the disc. The discs continue to shrink, and the bones in your spine actually start rubbing together. And not only can that press against the nerves and cause compression and stenosis, it can also develop into arthritic conditions, and we can start to grow bone spurs due to stage 4 as well. It can be quite painful. Now I want to move on to tell you a little bit about bulging discs, which can be also diagnosed as spondylosis and degenerative disc disease. Discs show signs of wear and tear with age as we become older, so it's quite common in geriatrics. After a certain period of time with that wearing and tearing, the discs become less flexible, they become more fibrous, and you can see on the right hand side here the degenerative disc, where you can see some wear and tear on the image. The bulging disc, which is now there's pressure and compression between the vertebrae, which is causing the disc to bulge out to the side. According to the Mayo Clinic, it's kind of like a hamburger that's too big for its bun, okay? The hamburger's bulging out the side. That's the same that's happening with our vertebral disc in between our vertebrae. So to quote Mayo Clinic, they said a bulging disc is a condition where the soft center of the spinal disc pushes out of its outer ring. And this can happen to a number of factors, including aging, injury, and wear and tear. Herniated, ruptured, and slipped discs are essentially all the same thing. We have 3 different terms to explain the same medical issue. Now, unless there's acute blunt force trauma, herniated, ruptured, and slipped discs are usually a result of degenerative disc disease and can be categorized as spondylosis. It is a degenerative condition of the vertebral discs. What happens with herniated, ruptured, and slipped discs is the outer annulus fibrosus tears or cracks, and that allows that jelly-like center, the nucleus propulsus, to leak out through the tear of the annulus fibrosus of the outer ring. And when the annulus fibrosus tears, if there's pieces of that that are pressing against the nerve root, or when the nucleus propulsus, when that jelly-like fluid leaks out onto the nerve root, that can be really irritating to the nerve roots of the spine and cause pain, significant pain, debilitating pain for some. Some people will have herniated, ruptured, and slipped discs and never feel a thing. Others have magnificent pain with it, and there's no medical explanation why some people have pain and some people do not. There are people walking around all the time with herniated, ruptured, and slipped disc and didn't even know they had it until they have diagnostic imaging and they are diagnosed with a condition. We don't have very many massage precautions or contraindications to work with degenerative disc disease. Sometimes massage can actually help the client feel better. And what happens when we do have pain and irritation is our muscles tend to get tense. It creates ischemia within the muscles. So when we provide massage and increase circulation, we can release some of that tension and ischemia, and the client usually feels better with that. Now, with DDD, you do want to make sure you do the obvious, which hopefully you learned in your rudimentary training, which is you're not going to press directly over a slipped, ruptured, or herniated disc or bulging disc as well. We don't want to worsen the condition, and it might be possible that applying pressure in the focal area, especially when there's an acute pain, that could worsen the pain, and we don't want to worsen pain. Always do no harm. The other massage precaution and advisement we would provide for bulging, slipped disc, herniated, and ruptured is you want to make sure you're properly bolstering your clients, okay? With geriatrics specifically, if you are going to lie them in a pronated position, you need to put that bolster underneath their ankles. Don't ask them if they want it. They're not the trained professional. You are. Make sure you put that bolster underneath their ankles. That helps that spinal curve alignment stay in proper alignment. When you have a client lie flat on a massage table, regardless of age, it creates unnatural pressure and compression on the spine. So you don't want to do that. When the client is lying supinated, you of course want to put a bolster underneath their knees. Again, do not ask the client. I have seen some cheaper massage tables advertised with bolsters, and they come with a bolster that's like 1 or 2 inches high. Things like a rolled bath towel are inadequate. I would say at least a 4-inch height bolster would be appropriate for both ankle and knee elevation to keep the spine in proper alignment when working with spondylosis or any type of degenerative disc degeneration. Now we're going to review the aging process with joints, which deteriorate over time and can cause all types of problems. As we age, our joints become less flexible and stiff, and that results in geriatrics usually taking shorter steps to help with balance issues and to help them prevent from falling. Our range of motion usually decreases, and wearing of cartilage can be an issue, especially in the hips and knees, which we now have joint replacements commonly exercised in the elderly too. There are many arthritic changes that happen in the joints that can also produce pain and decrease function. One of the nice things that we have to provide you with this training is we can teach you from research that with geriatrics, massage has been proven to help increase lost joint range of motion. Here is a study that was published in 2016 in a bodywork journal that showed that ama massage, which is a Japanese massage, increased range of motion for shoulders. Arthritis and old age almost go hand in hand. It's hard to get older without arthritic conditions. The 3 most common arthritic conditions that we can find in seniors and geriatrics are osteoarthritis, rheumatoid arthritis, and gout. We'll review all 3. Arthritis is one of the most common diseases in the U.S. amongst Americans, and it's more prevalent as we age into our senior years. Depending on the type of arthritis, signs and symptoms can include pain, stiffness, swelling, decreased lost range of motion, and an impaired functional ability as well. We have people out there playing tennis and golf and pickleball and more in their senior years, which is inhibited oftentimes by arthritic conditions. Osteoarthritis is the most common diagnosed arthritic condition amongst geriatrics. It's a chronic disease that occurs over time as the cartilage wears and breaks down. As our cartilage wears and becomes thinner and thinner, you create a bone-on-bone situation, which can be quite painful for some, and the joint can deteriorate so much that it could be a candidate for joint replacement. In the pictograph shown here on the right here, we have a lot of statistics that we can review about osteoarthritis. First of all, your risk factors include heredity. If it's in your genes, it's in your genes. Even if you have a sedentary lifestyle and you don't move around a lot, causing wear and tear on your joints. If your parents had osteoarthritis, you're more likely to develop it yourself, regardless of your own activities of daily living. Also, age and obesity can contribute to wearing of the joints in an osteoarthritis situation. Women are more prevalent to have osteoarthritis more so than men. Hormones, infections, and diabetes mellitus, as well as mechanical injury, can all increase your risk of osteoarthritis. Signs and symptoms are that of regular arthritic conditions, swelling, pain, and so forth. Managing osteoarthritis can include losing weight if you're overweight, exercising and moving a little bit more, medication, sometimes surgery is performed. They might do a meniscus repair or something. And of course, joint replacements are now being exercised when there is an arthritic condition that is beyond all help. Now, in osteoarthritis, we can also help clients feel better through massage. And if there's acute osteoarthritis where there's extreme swelling, we wouldn't massage the focal area where swelling is present because that's a contraindication. However, if it's a chronic condition and this person's had swelling for a really long period of time, performing something like a skin moisturizing session with joint mobilization might relieve their pain. Osteoarthritis can cause other medical issues, such as what you can see with these hard, bony swellings and growths on the interphalangeal joints of this woman's fingers. When these hard bony growths are on the distal interphalangeal joint, they're considered Herbert's nodes. And you can see on the middle finger of this geriatric female also is swollen with hard bony growth. When you see them on the middle interphalangeal joints of the fingers, they're called Bouchard's nodes. So when you see these hard bony growths on the distal fingertips just below the fingernail, they're Herbert's nodes. Here's a medical illustration that shows Herbert's and Bouchard's nodes on the distal and middle interphalangeal joints of the fingers. Your massage and bodywork precaution for your geriatric clients who have these hard, swollen, bony growths is do not press directly over the area. You can probably do some joint mobilization and skin moisturizing, but you wouldn't want to do like a money sign down the fingers when they have these hard, swollen growths in the interphalangeal joints. You don't want to do anything to irritate an arthritic condition. And pressing directly on hard bony growths resulting from arthritis could be painful and create new swelling because of the new pain. Bone spurs, which are medically known as osteophytes, are a common side effect or issue that can result from osteoarthritis. They're bony projections that develop along the edges of bone and are often found in joints. So what happens with osteoarthritis is that as that natural cartilage wears away and it doesn't really build itself back as we get older into our geriatric years, you start to get a bone-on-bone condition. And when you have that bone-on-bone with that friction and irritation and pain, that can stimulate new bone growth. I wish it would stimulate cartilage growth, but it doesn't. It really stimulates more new bone growth. And that's how we develop bone spurs, also known as osteophytes. Now, here is a medical illustration of a bone spur at the posterior portion of the calcaneus. This is one example where bone spurs are occurring that are not inside a joint or around an immediate joint. This often occurs with plantar fasciitis. However, in the next slide I'm going to show you, it's a cadaver slide. So if you can't handle seeing cadaver tissue, please turn away from the screen a moment. I will show you what bone spurs look like in real life. Here in the shoulder joint, there are 3 arrows, 1 black and 2 white arrows showing osteophytes on the ulna. So these osteophytes are probably a little bit further in the shoulder capsule, irritating the shoulder, in addition to the exterior portions of this ulna as well. So these bone spurs are commonly found in geriatrics. Many times people don't even know they have them, but sometimes They can be painful, they can develop swelling, and they can get into areas where it causes more friction for the client in the joint. And when that happens, they usually go in and surgically remove them. Here is a popliteal cyst, also known as a Baker's cyst, which could also result from osteoarthritis. So there's a number of different medical issues that result from arthritic conditions, which we've just reviewed with you, whether they are Herbert's nodes, Bouchard's nodes, cyst, osteophytes, and more. WebMD reports on these popliteal cysts, and I'll read it to you. They're caused when excess joint fluid is pushed into one of the small sacs of tissue behind the knee. When the sac fills with fluid and bulges out, it's called a cyst. The excess fluid is usually caused by conditions such as rheumatoid and osteoarthritis that irritate the knee. Now, sometimes they'll drain these, but usually the fluid comes right back. It can also be treated with medication. When it comes to any of these conditions, whether it's the nodes, the osteophytes, or cyst, we're not going to press into any of these arthritic resulting conditions. They're usually painful. We don't want to create more new pain, which could create more new swelling. Out of the 3 most common types of arthritis, the next one we're going to review is rheumatoid arthritis. Rheumatoid arthritis only affects perhaps about 2% of geriatrics, so on average, 1 in every 50 clients might have rheumatoid arthritis. It's an autoimmune disease where the body attacks itself, and your risk to acquire or develop autoimmune disease increases with age. It's also more likely to occur in women more so than men. Now, with rheumatoid arthritis, you can find 70% of these clients having problems in the fingers and wrist. 90% of rheumatoid arthritis people will have problems in the feet. And there are complications if somebody has a heart attack or stroke with rheumatoid arthritis. Their recovery will be much more difficult. To manage rheumatoid arthritis, sometimes we can do things like a skin moisturizing session with joint mobilization, as long as they're not in any type of acute flare-up. Also, people should stop smoking, not drink alcohol. They should make sure they're getting proper minerals in their diet, vitamins and minerals. They should exercise, and there are some drugs that can help minimize the effects as well. Now, osteoarthritis is more of a wear and tear arthritis where it increases in age as we wear away our joints, and this mostly happens in our weight-bearing joints. However, rheumatoid arthritis is usually found in the smaller joints of the body. That's why you see such a high prevalence rate in the hands and fingers and feet. But rheumatoid arthritis can also affect not just smaller joints in the body, but the heart, muscles, blood vessels, eyes, skin, and nervous system. Now, one of the things that we need to be aware of as massage therapists is rheumatoid vasculitis, which is also known as RV. 1% of rheumatoid arthritis clients can develop RV. Okay, and it's a skin rash. It happens because the autoimmune flare-up, we actually attack our own blood vessels, which causes these skin rashes and ulcers when we're not getting proper circulation to our dermis. So this is what it can look like on the left-hand side of the screen here. Rheumatoid arthritis doesn't just affect the joints, it can affect many things within the body. And if it's affecting the nervous system and there's neuropathy where somebody's feeling numbness in an area, that would be a bodywork precaution or contraindication. You do not work in areas where the clients cannot feel what you're doing. So for rheumatoid arthritis, bodywork and massage precautions and contraindications. Whenever there's a neuropathy, if they've developed this, we're not going to work in the area. If they have RV, we also don't work on broken skin. These are local contraindications. However, if somebody has an acute flare-up of rheumatoid arthritis, they're in serious pain, this developed with an onset of like within an hour, that's a flare-up. And it's thought that massage might stimulate the flare-up even further, even touching the client. So with that type of client, I might just do energy work or Reiki session where I'm not really pushing around or increasing circulation. When the client's not in a flared up state, when they don't have this acute onset of extreme pain, then you might be able to do skin moisturizing sessions, regular massage, joint mobilization, or whatever the client can tolerate. Now, we do have some research to back up our work when working with rheumatoid arthritis clients. This is a random control trial. And what's great about it is random control trials are the gold standard of research. You really can't get a higher standard than an RCT. It was published back in 2016. And the title of it is The Effects of Aromatherapy, Massage, and Reflexology on Pain and Fatigue in Patients with Rheumatoid Arthritis. Now, they had 3 different intervention groups. One was aromatherapy massage was applied to both knees of rheumatoid arthritis clients for 30 minutes. The second group received 40-minute reflexology to their feet. And the third group had no intervention whatsoever. And when they compared their pain and fatigue scores before and after the intervention, they found that pain and fatigue significantly decreased in the aromatherapy and foot massage groups. Foot reflexology groups. They did find that the aromatherapy massage might be a little bit more effective than the reflexology, but they did the reflexology for a longer period of time. And what's most important is both were found to be effective. So they recommended from the research that this is a great non-pharmacological option to help rheumatoid arthritis clients with pain and fatigue. Now again, I would only work with your rheumatoid arthritis clients when they are not in an acute flare-up. When they're in an acute flare-up, you may make their situation worse. If they absolutely insist on it, I might only do 10 minutes in an area and tell them to go home and see how it feels, if it feels better or worse. If it doesn't feel worse, if it feels better, then come in tomorrow and I'll do 20 minutes. And the next day I'll do 30 minutes. And that might be inconvenient for them, but you really don't want to have a client end up worse after your massage or body work. That would be considered a medical error, especially if you're there to treat their pain or fatigue and it worsens after your body work. Gout is the last arthritic condition I'm going to review with you with the 3 most common arthritic conditions that can be found in geriatrics. This is a picture of a person who does have active gout. Can you see the difference from the left to the right foot? How swollen and red, it almost looks waxy, right? With this client who has gout. Now they're standing and weight bearing. If you have gout, you should not be standing and weight bearing. It's advised to get off your feet, put your feet up, ice them, and relax. There are some prescription medications today that treat gout very successfully. We're not really supposed to recommend prescriptions to clients, but what I've done when I worked in a country club that was primarily made up of geriatrics for several years, I used to tell them, oh, I heard, this other client who's suffering with gout right now just got a medication from their doctor, and within the next day they were golfing without pain, without swelling or anything. So you might want to chat with your doctor. And when clients would tell me that their gout was relieved with these prescription medications where they all knew each other, it's like, oh, I know another client right now who's suffering with it. Do you mind if I have them talk to you? I can't tell them that you come here for massage appointments, and I can't tell you who they are. But would you mind if I tell them that, especially if they're friends and they play cards together every Wednesday, would you mind that I tell them that, you got this medication and they can ask you about it? So with gout, it's very painful, and it's something that does resolve itself over time, but it's not something that we would massage to make better. When you have acute swelling like this, it is contraindicated to work locally in the area. Now, gout is caused by a buildup of uric acid within the body. Our body is not eliminating enough uric acid, and therefore, when it's collected at the most distal parts of our body, usually around the feet. That's the furthest from the heart, right? And the big toe. That's where gout is most commonly developed, although it can develop in other joints such as knees and fingers and thumbs and so forth. Uric acid, when it's further from the body where our body temperature is cooler, it can develop into these crystallized, almost like shards in the joints. And when you have something prickly or a shard in your joint from these uric acid crystal buildups, it causes that acute swelling you just saw on the previous screen. Here are two medical illustrations showing gout. On the left, you can see that gout developing in the interphalangeal joint of the large toe. That's one of the most common areas you'll see gout develop. And we also see gout depicted in the knees on the right lower medical image as well. Physically, it will present as warm, red, swollen, and very painful. And a client might come to you with gout because they have pain and they don't want to go see their doctor. But if you see these, it could also be a blood clot when you see warm, red, swollen, blood, painful. So I always prefer for a client to have a diagnosis. I might not just avoid the area and provide massage elsewhere, because if I increase circulation and they have a blood clot, that could be life-threatening, right? And we need diagnostic imaging, we need blood tests and so forth to make these diagnoses. We do not provide these as licensed massage therapists, so they really need to see a doctor and get this diagnosed. Now, it's interesting, gout is usually developed from what I call the country club disease. As a country club disease. Things like red meat, seafood, alcohol, and beans, especially beer and stuff like that. These are purine-rich foods, okay? And these purines, which if we don't eliminate enough out of our body, and as we get older, we have less processing, more and more develops and accumulates in our body, and we're less able to eliminate it, especially as our diet changes if you go to those country clubs every day. So that's how we end up with gout. On the left, you can see what gout looks like on an X-ray image, and you can see literally the buildup of swelling in foreign material on that big toe with those uric acid crystals. You might hear gout referred to as gouty arthritis as well. And again, it is a local contraindication. Once they get that diagnosis that this is gout, you can still work on the client. It's not like you're going to increase circulation of those shards or crystals throughout the body. They can have massage elsewhere. That'll probably decrease their pain level and relax them and stuff like that to have a massage. You're just never going to work in the local area where gout is present. When someone's joints deteriorate to an intolerable level, usually it's weight-bearing joints such as the hips and knees. They're now being replaced for the past approximate 50 years. And we've made some advancements with our joint replacements, which I'm going to review with you right now, and how this impacts you as a licensed massage therapist. I feel joint replacement is a relatively new medicine, a new medical practice. And it's a popular one as well. I live in the village as a retirement community now, and every week I know someone who's going in for joint replacement surgery, weekly, literally. They have joint replacement centers down here where that's all they do is joint replacement surgery all day in these clinics. Which is kind of crazy, but they're probably popping up more and more around retirement facilities like where I'm living. Our life expectancy, we're living longer. And as we live longer, our joints are wearing out because, sometimes we're more active, sometimes we're more sedentary. We don't move at all. And if we're overactive or we're sedentary and not moving, both of these could have deteriorating effects on our joints. We also have repetitive use injuries that we're not used to and we weren't experiencing 100 years ago. 100 years ago, if you were a farmer, you were chopping wood and seeding the fields and chopping hay and riding horses to and from to get supplies. And you climbed up the stairs in your house and you walked everywhere. You might have bicycled places. So you're removing your joints in all different ways, which is really healthy. But today we might spend 40 hours at a keyboard, okay, where we're just sitting all day. And then we might go running at night because we sat all day. So we go from 8 hours of sitting to an hour of using our joints, almost inflaming them. And so that's, the way we're living today, the way we're treating our body today, that's a tremendous strain on our joints. And because we're living longer with so much additional new strain, repetitive strains, now we're, having these joint replacements, which are often successful and allow for a better lifestyle for most geriatrics. I feel joint replacement is a relatively new medicine, a new medical practice. And it's a popular one as well. I live in the village as a retirement community now, and every week I know someone who's going in for joint replacement surgery, weekly, literally. They have joint replacement centers down here where that's all they do is joint replacement surgery all day in these clinics. Which is kind of crazy, but they're probably popping up more and more around retirement facilities like where I'm living. Our life expectancy, we're living longer. And as we live longer, our joints are wearing out because, sometimes we're more active, sometimes we're more sedentary. We don't move at all. And if we're overactive or we're sedentary and not moving, both of these could have deteriorating effects on our joints. We also have repetitive use injuries that we're not used to and we weren't experiencing 100 years ago. 100 years ago, if you were a farmer, you were chopping wood and seeding the fields and chopping hay and riding horses to and from to get supplies. And you climbed up the stairs in your house and you walked everywhere. You might have bicycled places. So you're removing your joints in all different ways, which is really healthy. But today we might spend 40 hours at a keyboard, okay, where we're just sitting all day. And then we might go running at night because we sat all day. So we go from 8 hours of sitting to an hour of using our joints, almost inflaming them. And so that's, the way we're living today, the way we're treating our body today, that's a tremendous strain on our joints. And because we're living longer with so much additional new strain, repetitive strains, now we're, having these joint replacements, which are often successful and allow for a better lifestyle for most geriatrics. We'll first review hip joint replacements, and today we have two different procedures. One is the hip replacement can be provided on the posterior, and the second type of more modern procedure that we're doing today are anterior hip replacements. Anterior hip replacements are considered much better than posterior, which is more old school. Now, in anterior hip replacements, there is a small percentage of population that cannot receive it and must receive the old school posterior replacement instead. Those are people who are usually morbidly obese, they're too large, and they're not able to make the incision in the front and be able to see what they're doing. They're going to have to cut in the back instead. Now, with anterior hip replacements, there have been a variety of incisions being made for this anterior process. It's considered a highly skilled surgery that requires special operating equipment. There's a table that is used, it has to be ordered. It's probably very expensive, that literally retracts the leg almost out of its joint. And you need that special operating table for it to provide these surgical hip replacements when working the anterior. Now, this is what the more old school anterior hip replacement surgical incision looks like. That's all stapled up right out of surgery. However, they now are doing things like a bikini line surgical incision that might cut more muscle than this older school anterior replacement. They're already developing and progressing with the anterior hip replacements, which is really exciting to see because the anterior hip replacements have only been practiced for a little over a decade or so now. The reason why you would want an anterior hip replacement is it's faster recovery, less post-operative pain, less damage to the muscles. There's decreased risk of hip dislocation after the replacement is made, and it's a shorter hospital stay because they're not cutting as much tissue, cutting down your recovery and recuperation time. The problem with your anterior hip replacement is the way that they do this procedure. They have these retracting tools that they use to pull back the muscle instead of cut it like they do in the posterior. And when they are pulling the muscles, they're also pulling the nerves, including the femoral nerve. And this causes a patch of numbness that's probably around the size of an orange to a grapefruit for most clients, almost smack dab in the middle of the quadriceps, so near the rectus femoris. And that numbness, it kind of irritates some people when they have a patch of numbness there. The nerve is damaged, and I have never seen anybody resume feeling in that area. You can still do massage over the area, but if you're doing hot stone massage, try and avoid any areas where there's numbness or neuropathy or where a client can't feel it because, they could be injured. Also, cupping. I wouldn't put cupping there. I wouldn't do gua sha. I wouldn't do Graston technique or anything over that numb patch that regularly appears after anterior hip replacements on the front of the quadricep. Most people know that's going to be a side effect for the rest of their lives, but we need to avoid the numb area with these more aggressive techniques to avoid injury. Here is what a posterior hip replacement would be on real skin on a client. And the reason why surgeons did posterior hip replacements for so long is because it provides them a much better view of the hip as they're sawing away the bone and inserting implants to replace the joint. The surgeon will make a curved incision and it cuts a tremendous amount of tissue. Geriatrics who had a hip replacement a few decades ago and have not had it re-replaced, which often occurs, they probably have a posterior hip replacement. So the surgeon has cut the gluteus maximus, the tensor fascia lata, then they cut the deep lateral rotators, and then they sew all these muscles back together to allow them to heal. This can create a great amount of scar tissue. So if you're trained in cross-fiber friction to try and break down scar tissue and other techniques, this might be some great work to work over this surgical incision. if it's bothering the client, if they're finding their restrictive movement due to that muscular tension because all the muscles are scarred and fibrotic from where they've been cut and surgically repaired. Now, there are some massage and bodywork precautions for hip replacements. First, do not internally or externally rotate the hip on the massage table for, I would say, 3 to 6 months after hip replacement. And these do not matter whether it's anterior or posterior hip replacements. If you're working on somebody immediately after hip replacement surgery, do not internally or externally rotate that hip. You risk dislocation if the client's not relaxed and moving their leg with you. After hip replacement surgery, the hospital stay is usually 1 to 4 days. If it's an anterior, you might be in there overnight, where posterior hip replacements, you're usually in there for a couple of days. Although insurance companies are trying to kick people out of the hospital sooner and sooner now to save on cost. Sometimes anterior hip replacements might go home the same day. I do have one client that did that, but she was a little nuts because a couple weeks later she was out golfing, internally and externally rotating that hip, and she loosened the stem in her femur. And now her hip replacement is constantly bothering her, and she's going to have that surgically repaired. Full recovery of a hip replacement can take 3 to 6 months. Very long recovery period before it's fully healed. New bone usually needs to grow around the stem of the hip replacement in the femur. And if you do not have any type of new bone growth and that stem is loose, you're going to have a problem. So you want to allow that to heal. Common post-hip replacement problems can include things like infection and blood clots. So I would not work around the surgical area unless you're trained in something like manual lymphatic drainage and you have post-surgical training with, hundreds of hours of hands-on practice before you start doing that more advanced work. You can also have heterotopic bone formation. So abnormal bone growth around the replacement site as well, which can cause new problems. Sometimes tiny parts of the prosthesis can wear off and get into the blood supply, which can cause obstruction to the heart and brain, cause stroke and even death. That would usually only happen with something like a plastic implant, which has been used in the past. I don't think they use that as much anymore because of those complications. And of course, that infection, pain, swelling, all can occur around the surgical incision site. So we need to be careful working around these areas if you are working around them right after surgery. On the far right, you can see the materials used in joint replacements. And you can have metal on plastic, metal on metal, ceramic on plastic, ceramic on metal. In the upper right-hand corner, you'll be able to see that plastic that I talked about where particles can break off from the prosthesis and get into the bloodstream and travel to the heart and brain and cause problems. So if you ever see a focal area, if you're doing a knee replacement rehab and above that on the quadriceps somewhere, you see like this red swollen area, you might want to ask the client to go back to the physician and have that checked, because if there is any type of blood clot formation after a joint replacement, that could be lethal to the client. You might be saving their life. I mean, of course, it's painful. They'll probably want a massage to relieve the pain, but it's also a life-threatening condition that needs greater medical intervention than a massage. Knee replacements are often considered the most painful joint replacement surgery in the body, and people are doing ankle, knee, hip, shoulder, elbow replacements for joints, but the knees are considered the worst. Now in this picture here, I'm showing bilateral knee replacements, which is no longer performed by most surgeons. And do you want to know why? Because too many clients were dying when they were having both knees done at the same time. Now, if you have a geriatric client who had their knees done, you may find that they have had both knees done and they were done at the same time. And it was thought that that was better. It was one recovery period, one period of hospitalization, and so forth. But because a greater number of people died when they were having both knees done, they were under anesthesia with too aggressive surgery for too long of a period of time. They're literally cutting both of your legs. They now will only usually do one knee at a time, and you'll probably have the second knee done just a couple months after the first if you need both. Now, with knee replacement surgery, what happens is the whole leg swells like a tube. It looks like a PVC pipe that's really, really large when compared to the other leg, and that's just from swelling. Some people will swell less than others. It depends how well they're following their doctor's advice, if they're doing their PT, if they're staying off their feet or keeping their legs elevated and so forth. Clients often complain about their physical therapy because what PTs need to do is flex the knee. And I used to think that was barbaric because it's probably tearing tissue, creating even more swelling. But I see it now. They really need to get that knee flexion in there to have that knee replacement be successful. If they do not flex the knee and the client does not get proper range of motion back within a couple months, they will probably never get that range of motion because the tissues are scarring around the knee replacement, around that prosthesis that replaced the joint. And you need to start getting that scar tissue to be able to flex and stretch to increase that knee range of motion for flexion, or else you lose it. Now, I'm a very advanced practitioner. I've done lots of joint replacements. I no longer do knee flexion with the client. I make them go get their knee flexion exercises from the physical therapist because I've literally been sworn at, screamed at, told I'm done an awful job, and that's what the PTs are doing. They're doing the same exact thing. It hurts. It's painful. So now what I do is I simply do effleurage strokes up the leg with knee replacement, acute knee replacement. Maybe I'll be doing manual lymphatic drainage first, and then I add in some strokes towards the heart a few weeks later with my manual lymphatic drainage, right immediately post-surgically. There's a whole procedure and step list I follow to treat this, which we teach in our manual lymphatic drainage training. So knee replacements are something that you see in a lot of geriatrics. Joint replacements, whether it be knee or hip, the average age of those clients is in their mid-60s. So after your geriatric client has their knee replacement, they need to avoid kneeling, twisting, squatting, and minimize stair climbing. They'll do stair climbing with a physical therapist, but they shouldn't be going up an entire flight of stairs at home with their new knee replacement. Hopefully, if the bedroom is upstairs, they've found an area they're going to sleep on the couch downstairs for a week or so until that swelling goes down. We do have some massage precautions for knees as well. Just like hips, you would not internally or externally rotate the leg or knee because you don't want to cause any type of twisting that could dislocate those new prostheses. So you want to keep the knee as straight as possible. What I usually do is I'll lower my massage table to the lowest possible ability. It's usually 18 inches off the floor. And then I'll sit down and provide my manual lymphatic drainage or massage the first week or so after knee replacement surgery if I'm rehabbing it right out of surgery. The reason why is when the client gets on the massage table, you don't want them to sit and then try and, twist or swing their leg up. Usually it'll be so swollen it'll be hard to flex the knee anyway. So if you have the table down really low, they can put their hands behind them and lower themselves down on the table while keeping their legs straight. That's the goal. You want to keep that leg straight getting on the table so they don't twist it and dislocate it immediately after replacement. In addition to keeping the table as low as possible, if you're rehabbing a knee replacement, also known as knee arthroplasty, immediately after surgery, is to always work on the client in supinated position for the first week or so, maybe couple of weeks, depending on how they're healing and so forth. You don't want the client to roll over from pronated to supinated or supinated to pronated, because that puts the client at risk of twisting their knee and displacing the prosthesis, which usually requires more surgery. I mean, this is a tragic medical error if it happens. So I usually have that table super low. I'll try and get a chair that I can sit at with wheels on it. My last knee rehab surgery was a guy who was on the Harvard basketball team as captain forward at one point of his life. He's a geriatric, retired now, but he was like 6'4", and I'm doing these venous effleurage strokes on him, effleurage return, and it was just, you needed those wheels to roll up and down to do that long leg. So I can no longer squat or kneel on my own knees when the table's on the lowest level and I have a fairly thin client. So I'll sit down in my chair to work on these knee replacements. As long as it has wheels on it, we're good to roll back and forth as you work up and down that leg. There's one more thing I want to mention about joint replacements for geriatrics, because this little tidbit allows me to determine sometimes how aggressive I'm going to be if I'm going to stretch the client or provide deep tissue, ruling out that they're not on blood thinners and they're a good candidate and so forth. And that's cemented and uncemented joint replacements, whether or not cement is being used. If you have a healthy geriatric who does not have osteopenia or osteoporosis, they might be a candidate for an uncemented prosthesis during joint replacement surgery. To not use cement, which is considered to be the better way to provide a joint replacement, you need healthy bone. Okay. And keep in mind, when we're working on geriatrics, sometimes we can have really, really old joint replacements, techniques that are no longer practiced because innovations have improved the process. So sometimes you never know what you're going to get. But I try to ask my clients, did you have a cemented or uncemented prosthesis, to help determine how stable that prosthesis and joint replacement is. Uncemented joint replacements take a longer time to recover from. However, it's thought that they have a better bond when the bone tissue actually grows and solidifies around the replacement. It's harder to break or loosen. And that client might be, who has good, strong bone growth around a prosthesis, they might be a better candidate than somebody who's had cemented prosthesis with their joint replacements. It eliminates the worry about the potential breakdown of the cement, especially if a client has osteoporosis with continuous aging. Now, a very large population of geriatrics experiences bone loss as we grow older. So how do you do joint replacements with porous bone? It would can be considered impossible, right? Well, there's cemented prosthesis that can happen with joint replacements. In the lower right-hand corner, you'll see an X-ray of a prosthesis that has been placed into the femur bone for a hip replacement. And that prosthesis has loosened in the femur bone, which the joint could then be dislocated. The femur bone is more subjective to fracture, and they could also develop infections and other issues with that loosened prosthesis. So what do they do with geriatrics who have porous bone? They cement the prosthesis into the bone. And it's a good thing in some ways because it lessens the chance of infection. In the cement, they mix antibacterial material. And with that antibacterial material injected directly around the bone and prosthesis, the chance of infection with a prosthesis lessens, which is great, especially for a geriatric client. It's fast drying cement, and it really helps those prosthesis adhere to the bone. But it's thought to create a lesser bond than natural bone growth against the prosthesis. So it is a little bit weaker. And remember when I talked about blood clots earlier as being a possible side effect for joint replacement? Well, sometimes the cement can wear off, especially if we're experiencing bone loss and that cement breaks off. If it ends up in the bloodstream, then that can cause stroke, although the highest prevalence of that is not during joint replacement. It usually happens with spinal surgeries when they're injecting that fast drying cement. So because that fast drying cement dries within minutes, surgeons can also know whether or not the prosthesis is in the correct place during joint replacement surgery. When a surgeon is putting a prosthesis in without cement, it's the hope that bone will grow around it before the prosthesis is moving and rattling around and dislocated. So there are definite pros and cons with cemented and uncemented prosthesis. I like to ask my geriatric clients which they have, because the uncemented prosthesis is considered to be a little bit less stable. Now, this training unit is only to teach you how to work with geriatrics and all the medical issues and aging processes that might come up when working with your senior client. We're not necessarily here to teach you joint replacement work or reflexology or anything else we're bringing up. However, we are here to provide you tips and examples of body work that can be used with these various aging processes. To do that, we look up research that where it's been proven methods to work with geriatrics in various medical scenarios. And one of the research studies that we found and I paid for to review is this effects of relaxation techniques and back massage on pain and anxiety in Turkish total hip or knee arthroplasty patients. So what they did was they took patients who had hip and knee replacements, one or the other, and they provided relaxation effects and back massage, two different control groups, on these patients 1 day and 3 days out of surgery post-operatively. So when you're working with joint replacements, you don't always have to work on the affected area that received surgery. In this study that was completed in Turkey, they applied 10-minute back massages to these joint replacement recipients. The 10-minute back massage was performed in lateral position, which I personally would not recommend with somebody who's just had a joint replacement. This was probably done in the hospital where these patients could be moved into this position by nurses and or physicians. Usually in the lateral position, which is also known as a side lying position, the client would have a pillow under their head, and they would also have a pillow under their top knee. Now, if they had a knee replacement, they might not be able to flex that knee to get it up and over a pillow. I would probably want to work on someone in a seated chair to provide the back massage, but this is what they did in their research study. Now, what they found with these acute postoperative joint replacement surgeries is that the clients who received the massage had significantly lower pain intensity levels, their vital signs had improvements, and they were relaxed. They literally wrote, the massage interventions helped them to forget about their pain for a while and improve their anxiety state. And this was achieved through the Miguel Pain Questionnaire, which is a pretty reliable approach to measure these different scores. They propose that there is evidence with this study to use these relaxation and back massage techniques at bed rest times to decrease pain and anxiety. Now, throughout this training unit, where I focused on skeletal issues, including the bones themselves, joint replacements, arthritis, and more, I provided a lot of tips and bodywork suggestions and accommodations and more. However, if I did not provide something that's specific to your client with the skeletal system in this training, I highly recommend that you reach out to the client's physician or surgeon if you're working on them and unsure what to do with their medical condition. It's always safer to reach out and ask questions than be sorry because you didn't make the accommodations because you just didn't know. We hope you enjoyed the hour and a half we were able to spend with you here, reviewing many of the aging processes that happen in a geriatric skeletal system. We teach geriatric aging processes and accommodations to be made with massage and bodywork for skin, cardiovascular issues, and more. We either offer them in smaller training units or you can purchase a larger 12-hour course that covers most of them. To review further training, you can visit our website at ceinstitute.com, and we've also provided the URL address on this page that shows where you can look up specific geriatric bodywork massage and training. If you enjoyed this video, please follow us on YouTube and like us on our social media accounts at CE Institute, which will show our logo right here, and that's how you'll know you've found the right one. And until we see you in another training, be safe.